So this is a talk that me and Dan have done together, which is on injuries of the shoulder and the humerus. So Dan is also a PEM trainee. He's an adult ED reg who's doing his year of PEM. And you probably haven't seen him around either very much because he's on CIC with me at the moment as well. And what we'll do is we'll draw on some of Dan's adult experience as well when we get to the dislocations part of the talk a bit later on. So I'll get started, and then when Dan gets here, he will join us and he will do his bit as well. So I'm not going to pretend to be some kind of expert about shoulder and humerus injuries, and to be honest, they're probably the x-rays which I find the most difficult to interpret. And I think that's the same for many people. I think you learn quite a lot about the shoulder at medical school, and then the practical implications of the injuries is something you don't see very much, and that's because we see less shoulder injuries, I think, in children than we do of sort of forearm injuries. So it's less common for us to see. So there's a huge variety of injuries we see of the shoulder in ED, and the stories can vary from like a simple fall off the bed to really kind of high impact traumas. So the varieties of stories and injuries that you can see is enormous. Obviously, we've only got half an hour to cover things, so what we thought is we try and keep things a little bit simpler. So these are all the things we might see. So the kind of child who face plants the floor and lands on their shoulder, bunk beds, kids always fighting and falling off bunk beds, monkey bars, and then we've got a lot of children who are very competitive athletes. So you do get some athletic injuries as well, and some kind of high level sporting injuries. We've also got a lot of motocross and BMXing and things like that. So you'll see injuries from those as well. A group that often gets forgotten is the children with disabilities as well. So a seizure can be enough to dislocate your shoulder. And I've seen children with fractures as well from seizures just because of the prolonged muscle contraction. So they're a group to consider as well. So the variety is huge, but actually in terms of what we see in children, the diagnosis is a lot less varied. So the majority of what we see is the clavicle fractures, and you can get ACJ injuries as well. So they're kind of the baked beans of the shoulder injuries. They fill up most of the plate, and you see quite a lot of them. We do see some humeral fractures, not that many, but a good fall off the monkey bars or a good fall off the bunk bed, you might fracture your arm. And the bit that we see the least of, which everyone always finds the most exciting, is the dislocations. So I will completely hold my hands up and say I have never seen a shoulder dislocation in a child. I've seen a couple in an adult, and I've seen people put them back in adults a couple of times. The children who I've seen who had dislocations maybe had it pre-hospitally and then it got popped back in. So what we're going to do is Dan's going to have a chat to us about dislocations and some of the techniques there. So in terms of making the shoulder a bit simpler, I know it's only the 3 bones, but the scapula in particular is a bit of a complex shape, and I think the terminology confuses some people. So, and it definitely confuses me. So, coracoid is it literally just means curves, like the beak of a crow, and so that's your coracoid process, which I'll show you a picture of in a minute. Acromion in Latin just translates to the highest point of the shoulder. Glenoid means shallow socket, and labrum is lip. So they're the different bits of your shoulder. So this is the anatomy, so reasonably boring picture, but just literally showing the bones. So you've got that curved beak bit of your coracoid here, and you can see here you've got your glenoid, and then you've got this lip here, the labrum as well. And then your acromion is the highest bit of your scapula here. So you've got your acromion come around there. I've drawn on rather artistically here the axillary nerve. And so this comes down from your brachial plexus, from the posterior cord, and it wraps around, goes behind the neck of the humerus, and then it comes out anteriorly here. It supplies muscle innervation to your deltoid and to your teres minor as well, and it gives you the sensation to the upper lateral part of your arm. So that's the regimental badge area that you learn about at medical school. So it gives you the sensation into that area. It's important to think of the axillary nerve, because if you dislocate your shoulder, so your shoulder normally in a dislocation will move anteriorly, so it'll move along this grey arrow here. You're going to stretch your axillary nerve, and that might give you some symptoms. So you might notice that they've lost tone in their deltoid muscle, and you might notice that they've lost sensation on the lateral bit of their arm. And the same with a fracture. If you have, where this grey line is here, if you have a fracture going across here, your axillary nerve is at risk of injury. So the applied anatomy here really is the importance of checking the function of your axillary nerve, and thinking how those dislocations and fracture might stretch it or damage it. So in terms of the ligaments, so there's a lot of ligaments attaching to the lateral portion of the clavicle here, and where it joins to the acromion. They've all got different names based on what they go from to. The applied part of this is the distance is important. So on an X-ray, we can only see bones. We can't see ligaments, obviously. So, but what you can do is you can measure these distances. So you can measure your coracoclavicular distance, and you can measure your acromioclavicular distance here. And if that distance is widened, that indicates to you that those ligaments might have been torn. So when you're taking a history for someone with a shoulder injury, it's always important with any upper limb injury to document whether the patient is right or left-handed. Presentation to the mechanism, what actually happened for them to have this injury, where the pain is and where the pain goes to. Stiffness and instability is looking more at sort of the chronic changes and whether there's been a kind of a background history of problems with this joint, and sensory changes as well. Past history, like we said, kind of in terms of background, previous fractures, surgery, hypermobility, whether they've got epilepsy or they've had seizures before, which have caused joint dislocations. And social, I think we forget this a lot of the time. There's a huge variety to someone. If you ask people if they play football, some children that you ask who say yes might just play football on a Sunday for half an hour. Some of them might be in a development team for Nottingham Forest or something like that. So they might be incredibly competitive at sports. I think the more you ask children about sports in ED, the more you actually find out that some children are competing at a very high level, and so injuries can have a particular impact on those activities. And also schooling as well. So some children with injuries will miss a significant period of time off school, and also if you've got something that's going to immobilize your upper limb, that's going to stop them from being able to do their writing at school. So they might need to have help in terms of laptops and things like that. So when we come on to examination, so I have blatantly stolen this off Sarah here, and I'm sure she'll come on to this in her elbow talk later, but you're assessing the whole upper limb. So what you learn at med school, so the look, feel, move test, and you're assessing those nerves and what's happened to the motor and the sensory supply to the limb. So Sarah's little infographic there is invaluable for that. This little blue bit here is that regimental badge area, which is the lateral cutaneous nerve of the shoulder or the humerus, and so that comes out here and that supplies that bit of skin there. Always important to document whether or not they can feel you touching there. And then you've got the range of movement of the shoulder. So obviously the shoulder can do lots of movements, but it's that abduction, which is something that we often test, and these are the muscles that are performing those various degrees of abduction. And the main thing to think of is, this girl here, she looks sad. She doesn't look like she's in A&E. She probably looks like she's more at the opening of the new Foss Park kind of shopping centre, but she's wherever she is in pain. And a shoulder is a fairly significant joint. It's a big joint, and it will give you a lot of pain if it's broken or the ligaments are injured or if it's in the wrong place. So analgesia is really, really important. All of these muscles as well are really strong. So the more analgesia you get, the more you relax the muscles, particularly if you're giving something like Entonox in a dislocation. So actually, the more relaxed you can get someone, if you've got a dislocated joint, the more likely you'll be get it back in the right place. So in terms of X-ray views, which is the bit that I think is the most difficult with shoulders, because of that shape of the scapula. and your acromion and your coracoid sitting there, the X-rays the radiographers do different views, and the pictures which you find online to explain what views they've done aren't the best. So this is what I did to try and understand how they get the various views of X-rays, and I would suggest everyone does this, because actually when you stand there and they actually put the beam on you, you can see how the beam is actually going and what view it's taking it from. It suddenly makes a lot more sense. So this is a standard AP view. And then we've got a scapular Y view in the middle, which I'll show you the X-rays of that in a second, and you've got an axillary view. And the views which you achieve in a child who's in pain will vary. So sometimes they won't be able to achieve they won't be able to get the child to stand up because they're in so much pain. So they might just be able to get an axillary view and an AP rather than the Y view. So that's why your different views you will get may change. But it's useful to be aware. These are the three, they tend to be the three standard ones that they will do. So I've taken this from Don't Forget the Bubbles, and they've got a brilliant page on interpreting shoulder X-rays, and they've got another one on ACJ injuries, which I've done as well, which I've used the slides from that. So I would recommend you have a look at them at some point. And the nice thing about these is they show you the X-ray, but they also have the writing on as well, so they explain to you all the various parts. So this is your standard view for your AP view, and you can see on that you can measure your acromioclavicular distance, and you can measure your coracoclavicular distance as well. The coracoid there comes across like a kind of circular projection because it's aiming right at you. And then you can see your humeral head sat nicely in your glenoid fossa there as well. In terms of the Y view, which I think is a more difficult one to look at, and I've put a picture on the side there, which is from one of the textbooks, which I find quite useful, which I've put in the references at the end. So what you're looking for with this is you're looking for the humeral head to sit in the middle of that Y, and that means that it's in the right place. And you can see there your coracoid, because it's from that different view, does look a bit more like that crow's beak, that curved shape. And then this is an axillary view as well, so you don't always get an axillary view, but quite useful in dislocations or if you've got suspected joint instability as well. So that's the various parts marked on there. And the way I think of that is it's a bit like a hand kind of grasping around the humeral head, so you can see the 3D nature of the joint from that view. So the most common thing we see is clavicle fractures. I thought we should go through those first. So if you think about the clavicle, you can divide it into three little bits. So you've got the most medial, the middle bit, and the end bit. And you can read lots of stats about clavicle fractures and you know, which percentage each bit affect. But if you actually physically think about it, clavicle fractures normally happen from a direct blow to the lateral part of the shoulder, or a force coming in where this red arrow is here, and that will be projected along the length of the bone. The medial part of your clavicle is really strong. It's attached to your sternum and it's the widest bit, so that's unlikely to fracture. Similarly, the lateral part, although it's a bit thinner, it's got all those ligaments which we've just looked at, which are anchoring it down to your acromion and your coracoid. So that is also quite strong. The narrowest bit you've got is the middle bit, and that's not really attached to anything. So that's going to be the bit which you fracture, and that's why that accounts for 95% of clavicle fractures which we see in children. So we've got a guideline in our hospital for clavicle fractures, which is nice and simple. It's a flowchart, and I'm always a fan of a flowchart. And I'll show that on the next slide. So the things which we look out for with clavicle fractures is that there's no, and these are the things which it's useful to document in your examination. So when you're saying there's no skin tenting or breaks, and actually this one here, this picture at the bottom of the skin, is a few days later after a clavicle fracture, where actually the point of the bone was tenting over the skin, and then it started to break through, and this bit here is a bit of bone sticking out. So that is an open fracture. We want to make sure we aren't sending people home with really tented skin, because the chances that it might break through the skin. No rib or scapular pain. Well, when you're assessing for that, what you're actually saying is that there's no associated fractures of the scapula. or the rib. Normal distal pulses, so you can, so subclavian vessel injury is something that could theoretically occur because they lie underneath that bone. Normal limb sensation and movement. Well, in a clavicle fracture, they're not going to move their arm above 90 degrees because at that point they're going to have to move it past their clavicle, so they're not going to want to do that. But moving up until that point is telling you that there's no brachial plexus injury. And chest air entry equal bilaterally, that's making sure there's no pneumothorax or hemothorax if there's been a significant force. So this is our guideline, which basically goes through that. So if you're between the ages of 2 to 13, you just go home with a broad arm sling, so long as you haven't got a break in skin or significant skin tenting, and you don't get follow-up. We do this referral on the fracture pathway, clavicle fracture pathway, just as a safety net and just to highlight it on the system, but they don't actually get an outpatient appointment. And if they're under 2, they get exactly the same treatment, but they also get an A form because it's a fracture in an under 2-year-old, which is something we do for all children. We refer them for to safeguarding just for an A form referral if they're less than 2 and they've got a fracture. One thing I've found when I've had children with clavicle injuries that I've picked up and put them in a sling is often the angry toddler will rip off the sling and completely refuse to wear it. Don't worry about that. You can give the parents the sling to take home still and say they can always try it at home, but it's not going to cause a significant problem if they completely refuse to wear it. The lump will persist for about 6 to 12 months, and after that it should remodel and it should look normal again. So telling the parents there's going to be a lump there as the callus forms is a useful thing to say, otherwise they might have repeated visits to their GP because they're concerned. So ACJ injuries, so again, this is a Don't Forget the Bubbles picture, which is on their ACJ injuries blog, which I've put on the references at the end. So what you're looking for on an X-ray is normal alignment, which is that bit in orange. So you should have a line between your clavicle and your acromion, so you should be able to trace a kind of a rounded line under there. If you've got a step in that, then that's indicating that it might be an ACJ injury. You've got your ligaments here, which are drawn in green, which are the ones which we talked about those distances before. So if you have an ACJ injury, then what you might see on an X-ray is widening of these spaces here. So you can see here where the ligaments have ruptured, there is widening of this space here, and there's widening of the ACJ as well. It's typically caused by a force which is either superior to the shoulder or lateral to the shoulder, and it displaces that acromion inferior-medially. Kind of common sense here, but if you've got a low force, you're more likely to sprain something, so just kind of pull the ligaments a bit. If you've got a higher force, your acromio, this one here, your AC is more likely to rupture, and if you've got a really big force, then you might do your AC and also your CC. The way you look for it clinically is the scarf test. This is a video which is on Clinical Physio, which is quite a nice one you can find on YouTube. What this gentleman is doing to this lady here is he is holding her scapula still with his left hand, and with his right hand he's bringing her arm across, and he's trying to get this her elbow towards her left shoulder. And what he's doing this is he's stressing that acromioclavicular joint. And if you have an ACJ injury, you will get pain, and you won't get pain in your neck or kind of vague pain in your arm. They will get pinpoint pain over the ACJ, and that's that examination would be highly suggestive of an ACJ injury. So this is the way they stage those injuries, depending on how extensive the rupture is. I don't think you need to know these in detail. I certainly don't know these in detail, and I would look them up if I was concerned about them. But basically the first 3 is not an operation, it's conservative management and physio, and the more severe types would be referral to orthopedics and surgical management. The important thing to remember with AC joint injuries is lots of them have residual pain, so it might be an ongoing thing, and so physio referrals and things like that through the GP can be very useful. So the next thing I was going to talk about was fractures of the humerus. So We don't see these very often, and the ones I've seen have normally been high impact. So kind of a high fall from a monkey bars in a smaller child, or children who've come off motocross bikes and things like that. Most of them are managed conservatively because you've in a poly sling, because you've got the effect of gravity, which should over time just pull the pull the fracture back into the correct alignment, and the callus will form around it. In terms of it's useful to know some of the anatomy of the humerus, because humeral fractures are classified dependent on which part of the humerus they affect. So in this picture to the left, you can see the yellow is the anatomical neck of the humerus, this bit here, which is where it actually articulates in the joint, and then you've got the surgical neck of the humerus, which is further down. So in children 5 to 12, the thing you see the most is Salter-Harris fractures. So one thing I've pointed out here, so this is how they go, which is the standard for any kind of Salter-Harris kind of growth plate fracture. The important thing to think about in the humerus, and the thing that always confuses me and maybe confuses other people, would be when you get to your Salter-Harris 3, if you use your monomic and you go S is straight through, A is above, and B is below, well, that's a bit confusing because it looks like this goes above rather than below. I think if you remember, Salter-Harris 3 goes into the joint, and I know that doesn't work very well with the monomic, but it makes it a lot more sense in my mind. Then you will see that actually that will go through the head of the humerus. And so 3 and 4, the risk you've got here is that you might be affecting that blood supply to the humeral head, so you could be at risk of avascular necrosis of the humeral head here. The humerus does have ossification centres. The head is about 1 year, greater tubercle 3 and lesser tubercle at 5 years. One thing I haven't mentioned in this talk is the scapula also has lots of ossification centres. I think it has about 7, but I thought that was probably a little bit complex for this, just to give an overview. But your shoulder, like any other joint, is developing when you're a small child, so the X-ray appearances will change over time. I put this in as sort of an example of mid-shaft humeral fractures. This first one here is a spiral fracture of the humerus. So you can see when you trace the fracture line round, it kind of goes round and it kind of goes through the bone, and you can see the fracture continuing along here. That's a spiral fracture. Spiral fracture is normally associated with significant trauma or twisting like trauma. You've got a mid-shaft fracture here as well. So humerus is just in 2 bits here. This one here, I put in, I've never seen one of these fractures, but I thought it was interesting in terms of thinking about that radial nerve and how it comes down the arm. So your radial nerve comes along here, goes around the back of the humerus, and then loops round and comes out on the lateral aspect of the arm. Importance with that, it just kind of highlights that you should be doing your motor and your sensory assessment, so that rock, paper, scissors okay is really useful, because if you've got a nasty fracture like that, you'd be worried about your radial nerve when it's looping around, and the clinical thing you might see is that you would lose wrist extension, because that's the group of muscles that your radial nerve will supply. So rare, I haven't seen these. It's got a cool name. It's called a Holstein-Lewis fracture, but it's just something to remind you that that you need to be checking the nerves and documenting that the sensation and the motor supply is normal. So this is the point where I hope Dan has appeared on the talk.
Jen?
Yes.
I have.
He is here, as if by magic. So I will hand over to you, Dan.
Thanks, Jen. Well, I hope everyone can hear me. So Jen just asked me to talk about shoulder dislocations. So shoulder dislocations in children is not overly common. I've probably seen about 2 in my career so far. But what tends to happen in children, they tend to fracture their clavicle rather than dislocate their shoulder. But older children may, or sort of young adolescents may dislocate the shoulder. 90% of all shoulder dislocations are anterior dislocations. So when you see the picture on the left, and they describe it as a squaring off. So as you can see on the arrow, and that's because the humeral head has gone forwards and it's out of joint. So the you get a bit of a tensing effect with where the end of the acromion is and down into the upper deltoid. Rarer, you can get posterior dislocations. They classically happen after electrocution or seizures. What they will look like is that the patients will be locked in an interior rotation. So they'll be holding that arm inwards. On an X-ray, you classically get this light bulb sign, which you can see, and you will get widening of the humeral glenoid joint space. So they happen roughly between 5 to 3% of all dislocations are posterior dislocations. And then there's another type of dislocation called the inferior one, or called luxido erector. Again, these are even rarer, but occasionally you've seen them. I haven't seen it in a child, but I've certainly seen it in adult twice. And they basically, what happen is that instead of going anterior or posterior, they actually tuck into the auxiliary space, the humeral head does. And the patients will be locked in with their arm up high, and it will look like they'll walk into the ED like they're waving at you, but they can't move their arm. So if we move on, so the important thing about anything to do with reductions is traction. Slow, sustained traction to get over muscle spasm is the key to reducing anything. So whether it's a fracture or dislocation. Often with talk about fracture reductions, if you don't do the traction properly, sometimes you get periosteum slipping into the fracture site. So that's what happens. So traction will overcome that. So talking about anterior dislocation reductions. So essentially what you want to do is what you can see of the axial view is that you want to get the humeral head, which is anterior to the glenoids, you want to retract it down, tract it down with traction. So the humeral head is touching the lip of the glenoid. And then using external rotation and adduction, you want that humeral head to kind of go over the lip and then slip back into the joint. There are 101 ways of doing this. These are some of the common ones that I've come across and that I use. So Hippocrates method, which is basically traction and counter traction. So classically, what you're meant to do is put your foot in the patient's axilla and pull against, and whilst doing that, pulling the wrist to gain traction to try and pop the shoulder back in joint. Now, that commonly doesn't happen anymore because that's got a high risk of causing brachial plexus injuries. But what you can do is put a towel underneath the patient's chest, and with someone give you counter traction, you can try and pull. Cocker's method is one that certainly when I started emergency medicine, it was probably a very common one to do. And basically what you're trying to do with that is that you're trying to get the patient to, which is seen in the first picture, you are externally rotating the humerus whilst abducting the shoulder. And then as that humeral head is on the cusp of the glenoid, you flip into internal rotation and adduction. And hopefully that sort of fast, rapid movement will pop the shoulder back in. Caution with that technique, certainly when you're doing it, you will find that as you're externally rotating, the patient's not overly relaxed, you come up a lot of resistance. And if it's extremely painful, I wouldn't force it. I have seen someone break someone's radial humeral heads whilst trying to force that using that method. Another one I quite like is one called the modified Milch method. So you get the patient lying flat, as seen in the diagram, and with a bit of traction, you retract the humeral head, externally rotate the arm, and then slowly abduct the shoulder whilst putting a bit of pressure on the humeral head. I find that works pretty much most of the time, and that's my method of choice. Or if you're feeling particularly lazy, there's Stimpson's method where you can put, if the patient's lying supine, the effector shoulder, you basically tie a load of weights or a litre of saline onto her arm and basically let their shoulder hang down the bed, and you leave them for about half an hour. And again, that's quite effective. Other shoulder reductions, so posterior shoulder reduction, you've got something called the Diplala method, which you're basically doing the opposite of what you do for an anterior shoulder dislocation. So you mainly use traction and internal rotation as you're adducting the shoulder. And then with the inferior shoulder reductions, you basically, the only thing you can do is traction and try and push the humeral head as it's coming out of the axilla. The key with both of, certainly in the inferior one, is that they'll need to probably be quite well sedated. So you'll probably need procedural sedation, and Entonox or Penthrox, which may be coming into the paediatric ED sometime soon, may not be enough. So the other thing that doesn't help with reductions is the longer the shoulder's been out, the less likely you're able to put it back in. Certainly under Entonox, you then may need to have either analgesia or procedural sedation, so ketamine and propofol.
Thank you so much, Dan.
That's all right.
Moving on to this interesting character here. So this chap, you find out all sorts of things when you do these kind of talks, but he's he's a world record holder with the world's stretchiest skin, and this is him kind of stretching his neck over his mouth, which is rather impressive. And so he's got Ehlers-Danlos syndrome, and the reason I mention that is it comes up quite a lot with shoulders. So Ehlers-Danlos syndrome is type 1 collagen defect, and people are stretchy, they have this hypermobility, and this is kind of the classic thing that you learn and you all try to do at medical school, and most of you end up hurting your wrist. The thing with Ehlers-Danlos syndrome is it causes spasms and pain, and with that comes the anxiety of pain. And these children are at risk of subluxations, and the shoulder is one of the joints that can sublux. And when you've subluxed your joint, that gives you more pain, and it gives you more spasms, and it gives you more anxiety because your joint is out and you don't know when it's going to pop back fully again, and then it slips back in. Unfortunately, once it slips back in, that's not the solution to the problem, because this is just an ongoing cycle that these people have to live with. And I've certainly seen a few teenagers who come in recurrently to ED because they felt their shoulder go out at home or go partially out, and then it slipped back in and they've come to ED. There is a tendency, if these children don't have sort of a plan for them to get recurrent x-rays, they get told the x-ray is normal and they just get sent home, and that doesn't really solve the problem. So what I would say, and in these children, a lot of them are under orthopedics long term, and a lot of them, if you actually look on ICE, they will have previous letters from their orthopedic consultants which will detail in which situations it would be recommended to do an x-ray, and actually what their ongoing kind of package of care is at home. This link I've put at the bottom is it's on the Ehlers-Danlos site. It's written by one of the physios. It's really, really good, and basically the only way you're going to tackle this kind of ongoing cycle is through these things in the green box. So actually giving these children sort of coping mechanisms to manage that pain for when their joints do sublux. So breathing exercise physios, using a sling. So a lot of them will come in with a sling that they pop on at home, because once their joint has been out and it's spasming, it's at risk of slipping out a little bit again. So they will use their sling and put it on just to rest their arm. Heat can be helpful as well for the pain, explaining this process of their condition to them, and like I said, having agreed plans as well. So that's the end of our talk. I've just put these things up as sort of a, well, not a top tips, but things that we do that we've kind of found useful. So analgesia early, so any kind of minor injuries, children will be distressed. Children don't want you to examine them. They don't want you to pull their joint about and prove to yourself that it hurts them. So give them analgesia early, and you'll probably find you'll not only make them more comfortable, but you'll get a more accurate assessment of what might clinically be wrong with them. If you're ever in doubt, just ask a friend. So like I did with Dan for shoulder dislocations, there are loads and loads of people in ED who you can ask all the time. If it's in the middle of the night and you're in peds, there's a whole adult minors which is full of ANPs who will often be happy to give you a hand looking at an x-ray or suggesting what you might do with a particular patient. I've put that down twice because I think that's probably the most important tip. Visit the radiographers. They're a really friendly bunch, and it's really useful to find out how actually They position patients for particular views, and then you can understand in your head what you're actually looking at that black and white flat picture. They also put the red dots on the images as well, and if you've built up a bit of a relationship with them, instead of phoning them if the department's not too busy, it's easier to pop round, and then they can physically actually show you what they've seen on the x-ray that they're concerned about. In terms of complex patients, so like the kids with Ehlers-Danlos syndrome, or kids who've got metalwork in their joints, or kids who are under long-term orthopedic follow-up, so check on Nerve Centre, check on ICE, and look at their previous imaging and find out a bit more about them. We put slings on and we do a beautiful job in ED, but I am pretty sure that the vast majority of children, if they don't rip them off in the department, do rip them off as soon as they get home. And so I always tell parents as they leave just to Google how to make a sling St John's ambulance, and that's a really nice kind of 3-minute video that covers broad arm sling and high arm sling, and so parents can use that piece of cloth you gave them to remake their sling when they get home. That's the end of our talk. These are the references we used. So don't forget the Bubbles pages at the top I think are really good and really clear. They go into a lot more detail about the ossification centres of the scapula and the humerus than I did. So they're useful ones to have a look at. There's our clavicle fracture pathway, which you can get online. These 2 books on the side are 2 books I own and I find useful. They're small ones. I think they have them in the library. Likewise, if you work at in Leicester ED and you don't know whether you want to buy them and you want to look at them, just give me a shout and you can borrow mine and have a look at them and see what you think before you spend your pennies. There's Teach Me Surgery, went through the shoulder fractures, and then at the bottom there's that link for the Ehlers-Danlos website as well, which is really useful. So that's the end. If there's any questions, I'm sure Sarah will tell me. I'll have a little look at the chat.
Yeah, so thanks, Jen. Some of the questions have been answered, so that's fine. But there was one question about the sign and symptoms of subclavian vessel injury following a clavicle fracture. Now, I've never seen it both in children or adults, and I would imagine, you know, my impression would be sort of bruising, bleeding, neurovascular compromise of the limb. I would have thought would be the obvious obvious injuries. I don't know what you think there, Jen.
Absolutely. So that you can get mottling or pallor of your arm, I suppose, and a weak distal radial pulse, and you also might get a weak brachial pulse as well. So yes, exactly the same. So the thing is, you can wherever the injury is in the upper limb, just do exactly the same examination and make sure you document those things, and then you're covered for everything.
Yeah, no, that's great. Thank you very much, Jen. That's been brilliant, and there's lots of thanks in the chat for you.